So good afternoon, everyone. So I think we were waiting like just a few minutes to make sure that more people were joining, but I think we already have like a nice number of attendees. So then we will start. We'll start introducing already Sophie to everyone, and just waiting if more people want to attend. So welcome to the IMH to lunchtime IMH webinar. And today it's our pleasure to present Sophie Sowden to our webinar today. So Sophie is a lecturer at the School of Psychology at the University of Birmingham, and also she's affiliated at the Institute for Mental Health, here working with us, and also at the Center for Developmental Science at the School of Psychology. Sophie is an experimental psychology, and her main focus of research is in social cognition across the lifespan, and specifically, so her main research is focusing on autism, which is the topic that she's presenting today. So she's the PI of the U21 Autism Research Network, and so today she's presenting the preliminary findings from the last 2 years that this network has been launched, right? So thank you very much, Sophie, for talking today to all of us. So as a reminder, this will be around 40 minutes of presentation by Sophie, and then at the end we will have around 20 minutes of questions within the Q&A section. So just leave all your questions at the end of this webinar. Then you can see the section within the webinar of the Q&A. So you can write your questions there during the webinar, and I will be sharing the questions, and Sophie, she will be answering to all of them. So thank you very much, Sophie. And now this is
thank you, Isabel. Thanks for that very nice introduction. So I'll just share my screen and just shout Isabel if that's not working. I'll just put it onto full screen. And I'll set my own timer as well. Yeah, so thank you very much for having me. Thanks for the invite to speak at the lunchtime webinar. It feels like quite an honour, actually. So I'm going to be speaking about the U21 Autism Research Network. And this is a network that we set up actually just under 2 years ago now. And I'm going to talk about some of the lessons that we've learned along the way. And also it's the first time I'm presenting some of the preliminary findings from our first couple of studies that we've run around our network. So yes, I won't be talking about social cognition, but I'll be specifically talking about our U21 network. So to start with then, what is the U21 Autism Research Network? So it's a group of researchers from Universitas 21 universities, autism researchers from those universities around that U21 network, who came together around 2 years ago to try and start building a network to think about diversity and inclusion in autism research. And we were funded by a researcher resilience grant during COVID to really try and bring together these researchers, work together digitally to try and solve some of the issues in our research area. And we had two main aims to begin with. And the first of these was to organise an online public engagement event to really start sort of amplifying the voices of autistic people in discussions about diversity and inclusion in our autism research. And as a sort of follow on from that, to build an international autism research database so that we can really start to sort of pool our efforts in trying to make our research more globally representative of the autism community, and to run an initial few studies that look at sort of cross-cultural differences in some of the key priority research areas in autism. So we now have a website, so thanks to those that are involved in putting that together. It has lots of information about the events and projects that we've been running, so please do check that out if you want to. We have an email address, but also a sort of Twitter and YouTube presence, so again, please check that out if you want to know more after this presentation. I wanted to show this because we also have a really nice rich network of researchers. And so I'm presenting by myself, but I can't really do that without all the other members of the network. So you can see we've got representation at one of our network meetings from many countries around the world, and even some of those for whom it was sort of the middle of the night when we had our meeting. So we're always grateful for these meetings, and I think we learn a lot from engaging internationally and having discussions about, for example, participatory research and how each of us engages individuals with lived experience of autism in our research. And we had some really insightful discussions about the different ways of doing that. And I think there's a lot for all of us to learn from each other. And these were discussions that we weren't really having before the pandemic. So it's something that sort of brought us together with this funding. So on to aim 1 then. I just want to briefly highlight this public engagement event because I think there were some important lessons that we learned from the event. So we held it now just over a year ago, and we wanted to talk about diversity and inclusion in autism. And we had a couple of panels. So panel 1, we invited individuals with lived experience of autism. And then panel 2, we had individuals who are kind of experts in the field of the charity sector, clinicians and researchers, and many of these autistic themselves, to discuss diversity and inclusion in autism research. If you want to see the live stream of the event, which I do encourage you to do because it was really insightful and there's a lot of great content, and luckily you won't hear from me, you just hear from our autistic experts. And yeah, please do check that out if you want to hear more. And we do have Japanese subtitles as well, provided by our Waseda University team from Japan. So just to show you that this was an event that that branched across sectors, we didn't just have a load of researchers coming along to the event. We had a high proportion of researchers, but we also had representation from autistic individuals themselves, friends and families of autistic people, as well as people from across education, charity, clinician and government sectors, and of course just general interested members of the public. And just to point out, this doesn't represent everybody that attended. So we had around 250 people attend on the night, and we've had quite a number of views of our live stream since. So hoping that we're having a good impact. We also had really good representation from across the world. And obviously this was one of the main aims of the U21 network, was to try and have a sort of global reach and to represent global voices as opposed to just the University of Birmingham voices, which we're very used to being surrounded by. So you can see that even some people were attending from parts of the country that probably time differences didn't allow for that to be during their daytime hours. So thank you to everyone that attended the event. And at the event, we asked panel A to give us their thoughts on what autism means to them, the sorts of barriers and misconceptions that they, as autistic people, have felt they've experienced in either accessing diagnoses or misconceptions that they've experienced, and also how we can make society and research more inclusive for them. And I want to just highlight one or two things that I think, or one or two points that I think we can all learn a lot from, and highlight some really important points and things to think about in autism at the moment. And firstly, Sarai, who is a medical doctor but now turned into a medical translator across 4 different languages. She grew up in South Africa and now lives in Germany. And she described that if you don't fit this classical textbook picture of a young male with poor social skills, if you're a female or a person of colour, people will consider different explanations for your behaviour than autism. And I think she really nicely highlights here a problem that we have both in clinical and research settings, that we try to put people in boxes. And if people don't fit into those boxes as being, like she said, a young male with poor social skills, you're actually kind of excluding those people to be able to access diagnosis and also to access the support that they require and they deserve. And then looking at a quote that Maya made during the event, she said that she's been in unsuitable psychiatric units and she's had a lot of traumatic experiences because she's an autistic person trying to access a service that's designed for neurotypical people. And I think, again, this is a really central thing for us to think about at the moment, is how not just our psychiatric units or health systems, but also education settings and employment settings are not designed with autistic people in mind. And actually by not thinking about how we can make reasonable adjustments for autistic people, we're making their lives a lot more difficult, and we're making accessing core and simple things very difficult for autistic people. And panel B, we asked them to talk about their current priorities for research, barriers to inclusion and representation in research, and also how we can make that research more inclusive. And again, I just wanted to, before we move on to talking about data, just give you some insights and lessons that we learned from this panel. So Rubes explained how the hallmarks of inclusive research are where autistic people are present because of their expertise, and that could be their professional expertise or their lived expertise, rather than as a prop or a token. And I think for many of you that are part of the Institute for Mental Health here, I'm definitely preaching to the converted, because we have a lovely sort of youth advisory group where people with lived experience are involved in all our research. But I think we've got a long way to go in terms of making sure that autistic people are involved in every stage of our research process. And Rubes nicely outlines that there. And then finally, our own Dr. Caroline Richards highlighted that the tools that we have currently to identify if someone is experiencing anxiety are currently not good enough to recognise anxiety in someone who has a learning disability and autism. And again, I think this comes back to the idea of trying to create a one-size-fits-all approach to both medicine and also our research. So using tools that we've designed in one population and presuming that they are a good measure to extend to other communities, like the autistic community or people that are experiencing other identities as well. And just to finish, before I move on to the data, there was one live poll that we ran during the event, and I think it's worth highlighting because it links nicely to one of the studies that I'm going to present. And we asked all the audience members what they think should be a priority for autism research going forwards. And amongst a number of options that we gave people, the most popular was thinking about improving mental health or understanding mental health for autistic people. And as I said, that leads on nicely to one of the studies that I'm going to present, because I'll be talking about some global perspectives of mental health in autism a little later. But without further ado, let's present you some of the data. So aim 2 of our network was to really set up this online database where we could recruit from a more globally representative sample of autistic individuals. So I'm going to present to you just 2 of those studies. So I'm going to be talking a little bit about autism-related language preferences across the globe, and then also about autism acceptance, camouflaging, and mental health. And one of these studies is complete and one is ongoing, so it will be some kind of preliminary findings from those. So to start with then, language is really important, as we all know, but language is not always just descriptive, it can be quite performative as well. So we can use language to kind of express our stance on a topic. And I think that's no more true than it is in autism. So there is increasing discussion and in fact debate about autism related terminology, and the autism community have become involved in this and discussing, for example, whether we use identity first language such as autistic person, or whether we focus on person first terminology, so person with autism. And this debate really links to the idea that many individuals describe their autism as being part of their identity, as opposed to something that can be separated from them, a bit like a handbag, some of our participants describe. So my autism is part of my identity and I can't just put it aside. And so there was a really lovely paper in 2016 by Lorcan Kenny and colleagues that really expressed the preferences of the autism community towards identity first language. But this is also recently broadened towards thinking about other autism related terminology. So using terms to sort of segregate individuals into high and low functioning. And also, for example, how we refer to non-autistic individuals has connotations for how we describe autism itself. So you'll hear a bit more about that. But no studies so far, despite looking at the perspectives of autistic individuals in the UK and Australia, no study has investigated autism-related language preferences of a more global English-speaking autistic sample. And in fact, the discussions are often had between researchers and clinicians. And so we wanted to bring the voice of a global autistic sample into this. So you can see representation on the globe there for where our participants came from, but we have a total of 654 English-speaking autistic individuals that took part in this study from across the globe. and they either had a clinical diagnosis or they were self-identifying as autistic. And we asked each of these individuals to take part in a study, and we used a mixed methods approach where we have both quantitative data and qualitative data. So just to show you first the quantitative arm of this study, we asked all individuals to identify by selecting from a number of lists which terms they would endorse or be happy for others to use relating to 6 different categories. So the first of those categories was nomenclature, so just classic ways of referring to autism. We also asked people about their language preferences when referring to the person, so that's our identity versus person first language. Also when referring to diagnostic status, and when talking about broader conceptualizations of autism, so whether or not we're thinking about it as a neurological brain difference or a disorder. We also asked them about how they prefer to refer to the abilities of autistic people, and finally how they prefer that we refer to non-autistic people. And I'm going to talk you through this step by step, as it's going to be a lot on the screen, but you'll see each of those 6 categories that I just explained to you presented on the graph in just a moment. But when we ran 6 separate ANOVAs to see whether or not there were significant differences in terms of endorsement of terms, we found that for every category there was a significant main effect of term. So there were preferences across all of these categories in terms of the language that we should be using. So if we look at nomenclature, you can see that the overall most endorsed term was autism, and the lowest endorsed term was Asperger's syndrome, followed by autism spectrum condition, and there was sort of some endorsement, relatively high endorsement for autism spectrum disorder. If we look at referring to the person, you can really see here coming out this preference for identity first language, because people are endorsing the terms autistic person, neurodivergent person, and autistic to a much higher degree than they are endorsing person first language, so person with autism and person on the autism spectrum. And if we look at diagnosis, so in this global sample of over 650 individuals, you can see again this sort of preference for more identity first language, so saying that someone is autistic or is neurodivergent, as opposed to has a diagnosis or has autism. And then when thinking about talking about autism more broadly, there's quite a preference here for using terms such as neurological brain difference, and really a lack of preference for talking about disease and even disorder. And interestingly, also quite high endorsement of the term disability, and many autistic individuals express that by being part of the community for disability, this allows them to access kind of reasonable adjustments that they deserve and require in their lives. And then if we think about abilities, again, quite polarized here towards actually talking about challenges, differences and difficulties, and really not endorsing these terms such as deficits, impairments, and kind of functioning labels, so talking about low and high performance or poor or better performance. And finally, if we think about the way we refer to non-autistic people, there's a preference for describing these individuals as neurotypical people or non-autistic people, neurotypicals or non-autistics, and a real kind of rejection of terms such as healthy controls, typical people, typically developing people, because this kind of has connotations that if these individuals are healthy controls, that autistic people are unhealthy. And so that language is being sort of unendorsed or rejected by the autism community. So that's a kind of summary of the global sample that we tested for this study. And we then wanted to see whether or not these results actually are reflective of each of the individual countries. So are there any differences in language endorsement across our different English-speaking countries that we considered? And just to kind of precise the findings a little bit, we only found differences between country groups for 3 of these different categories. So we found differences for nomenclature, for referring to diagnosis, and when we talk about non-autistic individuals. So I'm just going to break those down to you very quickly now. So if we look at nomenclature, what you can see here is that you've got percentage endorsement on the y-axis again, and you can see we've got data from autistic individuals in Australia, Canada, Ireland, New Zealand, the United Kingdom and the United States. And we broke it down by country group when we had at least 50 individuals per group so that we had enough power to look at comparisons. And just to kind of summarize what you're seeing, you can see that quite nicely the overall preferred term is very consistent across countries, but we see a couple of nuanced differences. So in the UK, we seem to have higher percentage endorsement from autistic individuals for the term Asperger's syndrome, specifically when compared to the lower endorsement in Canada, and also higher endorsement in the United Kingdom for the term autism spectrum condition when compared to most other countries. If we then look at referring to diagnostic status, again, you can see sort of consistency in the most preferred terms and the least preferred terms. But we actually see again that the United Kingdom autistic individuals are preferring or showing higher endorsement for hazard diagnosis when compared to particularly the United States and Canada, who have lower endorsement of that term. And finally, again, when referring to non-autistic people, we have similar preferences in terms of the most endorsed terms, but actually a kind of difference here whereby the United Kingdom sample are endorsing the term control participants and controls significantly higher than are the other countries. So there are some kind of global differences in these language preferences. But just to sort of sum up that quantitative section, we can kind of see that there are differences between countries in the amount of endorsement or percentage endorsement of individual terms. But actually what we also see is that they are very consistent in the most preferred term to be used to describe all of these different autism related terminology. So for example, if we were to give advice on how to refer to each of these categories, for nomenclature, the most endorsed term would be autism, and this is highly endorsed across all the countries we looked at. In terms of referring to the person, identity first language again was preferred, as has been shown in UK and Australian samples. And when referring to diagnostic status, again, sort of identity first is autistic as opposed to has autism. And when talking about broader conceptualizations, focusing more on neurological and brain differences as opposed to describing it as a disorder. When referring to abilities of autistic people, there's a focus on differences, challenges and difficulties as opposed to talking about deficits or functioning labels. And finally, there's a preference when we're talking about non-autistic people to refer to neurotypical or non-autistic people as opposed to talking about healthy controls or typical controls. So that's the quantitative stuff. And now what we also did is we gave people the opportunity to tell us more about their autism related language preferences. And we had some really rich and lovely open text responses. In fact, from 414 of that original sample. And I just want to shout out to Connor Keating and Hannah Heath for all their work in coding this data because it was a huge job and obviously you can see lots of responses. So we went with reflexive thematic analysis to look at this qualitative data. And this is really because it's sensitive to exploring nuanced meanings within data and it's amenable to these really large data sets and kind of diverse perspectives. And from this analysis, we can see sort of 6 main themes with sub-themes arising from the data. And I just want to go over these very quickly for you because I think there's some really important points for us to think about. So the first theme is problems of differentiation. And this really relates to ideas about using terms to segregate autistic people. So such as Asperger's versus autism or high versus low functioning, and that these are sometimes described as harmful or inaccurate. The second theme relates to autistic people being different and not less. And many descriptions here really centered on deficit-based language as kind of harmful and again kind of inaccurate, with many of these so-called deficits often arising because of being placed in a world that was not designed for autistic people, and rather than necessarily any deficiency in oneself. The third theme that came out of these open text responses is autism is me. And I think this really nicely relates to the quantitative data where we saw identity first language being preferred, whereby individuals see autism as part of their identity and something that cannot be separated and should not be separated from them. But having said this, there are also comments that whilst autism is part of one's identity, it isn't all of them. So there are maybe other identities that are also important to them. And then moving on, claiming language and community really centres around using language that allows the person to sort of belong in a community. So that might be using the word disability in order to belong in a community and have access to reasonable adjustments that those people deserve within that community. And also that this language belongs to them, so that autistic people have a say over who can and can't use certain terms because it refers to them, and therefore the language belongs to them. Next, we have this really nice theme that I think is really important. So be concise, be accurate, and be specific. And many people outlined that whilst they agree and endorse the terms neurodivergent and neurotypical, they wanted to point out that those aren't synonymous with autistic and non-autistic, because whilst autism may be a sort of sub area within neurodivergence, they aren't synonymous. So being careful about when we use these terms is something that our participants kind of highlighted. And finally, the last theme I think really highlights to us the need to respect and ask for personal preferences from each individual person, rather than to presume that we necessarily know which terms to use. So just in summary then of the first part of the talk and the first study, whilst we see that there is some consensus across groups in terms of language to be used, there's actually no universally preferred language, and we can see that from both our quantitative and our qualitative data, that there's no one way to talk about autism. And so we would advise that identity first language could be used as a default, because that is the most endorsed language by the autism community. But actually, even better than that is asking individuals what their own personal or individual preferences are, is another really good way to think about language. We should be thinking carefully about the way we describe the characteristics of autistic people. So particularly we should be avoiding functioning labels that perhaps aim to segregate people in ways that aren't necessarily meaningful and can be harmful. And finally, I think the main take home is really to use language respectfully and in a way that empowers the autism community and the diverse and global autism community that we are representing in this study. Okay, so we're going to take a little bit of a sideways step. So that's the first study that we ran via the network. And now I want to tell you a little bit about another study that focuses on mental health in autism. So why is this topic important? Well, we know that autistic individuals are at higher risk of psychiatric and mental health disorders, and they often experience premature mortality by up to 2 decades. And between sort of 50 and 70% of adolescents and adults actually experience diagnosable anxiety and or depression as the most common mental health difficulties. These things can also lead to increased likelihood of poorer long-term outcomes, so things like social functioning within educational and employment settings. And therefore, I think it's really important for us to try and understand a little bit more about factors that contribute to poor mental health in autistic individuals. And one thing I wanted to sort of put to you today is this idea of the minority stress model. So this was put forward by Botha and Frost in its relationship to autism. And this model really describes that minority groups, so whether we're thinking about ethnic minorities, gender identity, sexual minority groups, or health minority groups, are experiencing higher levels of stress, so higher stress burdens that may negatively impact their mental health. And this might be something that can explain these health disparities that we see between autistic and non-autistic people. as we may consider also the autism community to be part of a sort of minoritized or minority group. And to this point, no study has actually investigated cross-cultural or cross-country differences in common mental health difficulties in autism. So that's one of the main aims of this study. And one idea that I want to also put to you as a potential contributor then to mental health difficulties in autism may be autism acceptance, because some of the kind of example minority stresses that have been given are things like everyday discrimination, internalized stigma, and also the need to conceal oneself. So we can think of autism acceptance as an individual feeling accepted or appreciated as an autistic person, with autism positively recognised and accepted by both others, so society and families and friends, and by the self as an integral part of that individual. And what we know so far is that, particularly from research from the UK, in the UK, autistic individuals, almost 90% believe that society either does not accept or only sometimes accepts them as an autistic person. And actually what we also know from Ailey Cage and colleagues' work is that external acceptance, so the acceptance that you feel from society and the people around you, predicts depression and stress, whilst personal acceptance, so one's own acceptance of their autism, predicts depression scores. So it seems that there is this important link between acceptance and experiences of mental health difficulties. And one thing that obviously with the network we can look at is whether or not there are indeed differences around the world in levels of autism stigma, and also differences in mental health, levels of mental health difficulties in autistic people. And it's perhaps, that there's a few studies really that it's perhaps expected that we may find differences in autism related stigma. So there are a couple of studies that look at sort of acceptance or stigma in university students and show that there are lower levels of acceptance in university non-autistic students in Lebanon and Japan when compared to the United States. And therefore, I think it's quite important that we look at this in a more global sample and kind of consider that we can look at the true impact of acceptance or of stigma on mental health difficulties in a global sample where we may expect acceptance to kind of vary. So to do this, we actually put together a registered report protocol. So for anyone that's not used to hearing about registered reports, this basically sort of flips the research process, whereby we have our paper accepted prior to collecting data. So as opposed to kind of collecting data and then writing the findings, we wrote the background, the methods and the planned analyses, and we submitted that prior to collecting our data. So this is a registered report protocol that looks at global perspectives on autism acceptance, camouflaging behaviours and mental health in autism spectrum disorder. And the aim of this registered report was to recruit over 300 autistic adults from our global U21 autism database. And we are recruiting these from many countries around the world. And we ask all individuals to complete an online questionnaire-based study to measure levels of autism acceptance, camouflaging behaviours and common mental health difficulties. And I'm not going to talk about camouflaging behaviours today. I'm just going to focus on autism acceptance and mental health because we're sort of 2/3 of the way through data collection, and this is a sort of preliminary data. But camouflaging behaviours are the sort of masking of autistic traits or individuals attempting to reduce the visibility of their autistic traits in social situations. And the common mental health difficulties that we focus on in this study are anxiety, depression and stress, just as was investigated in the study by Ailey Cage and colleagues. And the idea is to really look at some of those hypotheses, but in a more globally representative sample. And so far we are translating the questionnaire into French and Japanese, but we don't quite have that data. So I'll be presenting data to you from our autistic individuals in Australia, Canada, South Africa, the United Kingdom and the United States. And we currently have 193 autistic adults who have self-reported a clinical diagnosis of autism from these 5 countries around the world. And as well as various demographic questions that we asked them to complete the depression and anxiety and stress scale, autism acceptance questions, and the camouflaging of autistic traits questionnaire. And again, I'm going to be talking about the first 2 of these for the rest of the presentation. And the main aims of the study were to compare levels of each of these variables. So to compare autism acceptance levels, camouflaging behaviour and mental health across our different countries in groups where we have at least 30 individuals from each country. And then we want to replicate the findings by Ailey Cage, where she found relationships between acceptance and mental health in a UK-based sample. And we want to replicate this in a kind of larger and more globally representative sample. And we want to replicate the findings that levels of external acceptance predict depression and stress scores, that levels of personal acceptance predict depression scores. And then I won't be talking about these, but we also predict that levels of overall autism acceptance will predict the amount of camouflaging behaviour that an individual engages in, and also that the amount of camouflaging behaviour might predict anxiety scores. But again, I'm just going to focus on the acceptance and mental health factors today. So in terms of our preliminary results, so this is from our global sample. When we asked our participants whether they felt society in general accepted them as an autistic person, around a quarter of our participants said yes, which actually nicely is higher than that found in the Cage study, where only 7% said they felt accepted by society. But actually nearly a quarter still are saying no, they don't feel accepted by society. And 50% say only sometimes do they feel accepted by society. And therefore, we do find that reduced feelings of acceptance by society, as reported in the last week, was significantly related to greater reports of feelings of depression, anxiety, and stress, also reported within the last week. And when we enter this into hierarchical regression analyses, where we look at predictors of depression, anxiety, and stress, we set up step 1 of our model to investigate age, so demographic variables such as age, gender, age of diagnosis, and the other DAS subscales, to look at whether or not these variables do predict depression, anxiety, and stress. And then in step 2 of the model, we entered personal acceptance and external acceptance. And this is really to see whether or not these variables can predict depression, anxiety, and stress over and above these other demographic variables. And so when we look at the model for depression, we see that step 1 of the model is significant and predicts 66.4% of the variance in depression scores. But we also see a significant step 2 of the model, whereby an additional 4.1% of the variance or variability in depression scores can be predicted by step 2, so acceptance. And this was driven by personal acceptance being a significant predictor of depression. And you can see that in this graph here, where increases along the x-axis in personal acceptance are related to decreases in depression scores in autistic participants. And if we look at our results for anxiety and stress, what we see is that, again, step 1 of the model, so our demographic and other subscales, do account for a large percent of variance in anxiety and stress. But we don't see significant addition to the model when we move to step 2. So we don't see that personal and external acceptance are predicting anxiety and stress scores. And just to kind of follow that up, we have so far in our sample enough power to replicate these effects from the Ailey Cage study, so whereby acceptance does predict depression and that acceptance does not predict anxiety, but we are yet to reach the required sample to have enough power to replicate the effects of external acceptance predicting stress. So for this, I think it will be a bit of a watch this space until we've got our full sample to see whether or not we replicate the Cage study. Okay, and then when we do some comparisons by country group, we entered our variables into a MANOVA analysis, and we see a main effect of country of residence. And this is basically driven by the fact that we see significant differences in levels of anxiety, depression and stress between countries in our autistic participants, and also between levels of personal acceptance by country, but not external acceptance. And I'm going to break those down a little bit for you now. So if we look at anxiety, you can see that this is driven by the fact that autistic individuals in South Africa are reporting higher levels of anxiety when compared to all other countries that we sampled, and also that the United States have significantly lower levels of anxiety, particularly when compared to Australia and South Africa. And in terms of depression scores, you can again see that depression scores are elevated in autistic individuals from South Africa, but also from Australia, particularly when compared to lower levels of depressive traits in the United States. And a similar pattern is true for stress. So we see higher reported levels of stress in autistic individuals in Australia and South Africa, particularly when compared to lower levels of stress reported in the United States. And finally, you can see that for personal acceptance, there are differences across our different country groups, but this is particularly notable whereby personal acceptance is highest in the United States and lowest in Australia. So to summarise those findings in particular, we found that nearly 75% of autistic adults from our global sample felt that they are either not accepted or only sometimes accepted by society. And we found that acceptance by society in the last week is related to feelings of depression, anxiety and stress, also reported in the last week, whilst only overall personal acceptance was able to predict depression scores once we control for various demographic variables. And we also saw that lowest levels of depression, anxiety and stress reported in autistic adults were seen in the USA, and highest levels in South Africa, whilst also lowest levels of personal acceptance were seen in autistic adults in Australia, and highest levels of personal acceptance in the United States. And I hope that you'll agree that this is a really important priority area for autism research, and particularly knowing that levels of acceptance, both external and personal, contribute to feelings of depression, anxiety and stress, that this is really research that can inform a need for thinking about acceptance in general, so acceptance training, but also informing kind of mental health support that might be required for autistic individuals around the world. And so in terms of a general overview of my talk today, I hope that I've also demonstrated to you that the U21 Autism Research Network can be instrumental in representing the voices of a more global autism community. And also the benefits of international collaboration. So none of this would have been possible without the kind of agreement and all of the other sites being on board. And it's been really insightful to share knowledge and share practices amongst our network. I've also presented to you some preliminary data where we highlight both cross-cultural similarities, but also some cross-cultural differences in key questions such as the sort of terminology that we use to talk about autism, and also in terms of autism acceptance and mental health difficulties in autistic individuals. And going forwards, the future of the network, I hope that we can grow the network to become ever more sustainable and to really continue talking or amplifying the voices of autistic people in talking about diversity and inclusion in society and research. We are now kind of branching out of the U21 focused universities and looking for further funding, and also hoping that we can continue to make a difference with asking questions that the autism community think are important. And for now, I'd like to thank you all for listening. I also have to thank each individual site that's been involved in this research, because it's definitely not a sort of one university effort. And also I want to finish by thanking Connor Keating and Lydia Hickman for their hard work in collecting some of the data that I've presented to you today. And thank you for listening. I'll invite any questions I think Isabel will manage.
Thank you very much, Sophie, for such an interesting presentation, and as well, congratulations for this great effort that you are doing, like with different countries, just to advance on the research in autism. So at least for me, it was very clear all the work that you are doing, and I learned a lot, especially with all this terminology, and which I think is very important as well on the mental health in autism, which is, I guess, one of the main focus as well in the IMA. So now we have around 15 minutes for discussion and answering questions. So we already had like few questions in the Q&A. So I will start with those ones already. Some attendees they were including during your talk, and then as well, any of you, if you have further questions, please write them in the Q&A, and I will continue reading them. So we start, Sophie, if you don't mind, so we start with Christian Malone, and he's asking, so what percentage of your team have autism themselves, if any?
Of our team?
Yeah.
Yeah, good question.
I guess so this question was in the beginning, so I assume it's in the beginning. So when you were talking about the network and the people involved in the network, yeah.
Yeah, absolutely. So I think I struggled to work out the exact percentage. So we have as much as possible some individuals at some of our sites who are contributing from the perspective of an autistic researcher or an autistic advocate. So for example, in New Zealand, we work quite closely with Autism New Zealand. So one of the individuals, actually, I think we've just submitted the paper, but also on our paper and having read through everything we're reporting is autistic themselves, which I think is really, really important. And we also, for all of these studies, have consulted our Autism Research Consultancy Committee, both here in the UK and also in as many other countries where we had sort of participatory networks that we could consult. So yeah, I can't say exactly percentage of researchers, but we try to do that as best as we can. Yeah, thank you.
Then Rachel Ardebrook, our own Rachel. So then she's asking, the person-first nomenclature is very interesting and appears quite different to that seen in mental health disorders, for example, psychosis. Is there parallel with neurodevelopmental disorders?
Yeah, good question. Actually, it's something that I spoke to Matthew Room about as well recently, because that, particularly with psychosis, seems to be the opposite. I don't know if I can speak to all neurodevelopmental disorders. I think it really is focused quite heavily in autism, and I wouldn't like to say definitively, but I'd say it was more focused on autism than many other developmental conditions. If I'm wrong, someone can correct me in the chat.
Then Julian Winnet is asking, were there any differences in responses across age groups? I think these questions that refer when the study of the language preference study. Yes. So.
Yes, so that's a really interesting question, and actually at the moment we have looked to see whether or not we've got kind of matched age across our different country groups, and at the moment it's relatively matched. So, and it's fairly restricted. It's adults, so we're only recruiting adults of I think the average age is around 28. We haven't broken it down into ages. I'm not sure if we have the power to break it down too much, but I think that would be a really interesting question to answer if we could in a larger sample in the future. Yeah, thank you. Sorry, I can't give an answer to that.
No, I mean, and I guess that as well what you say as well, now you are, because these were preliminary findings, so I think as well something important to highlight. And then you have, of course, I mean, as you said, the future studies and things to consider for future research. So, I mean, the thing is
yes,
completely fine, but of course you cannot answer to other things at the moment. So,
yeah.
Thank you. Then Priti Perepa, how about pronouncing correctly, can you explain a bit more about your sampling and how you address the issue of bias in sampling? As it has been noted, most autism research is dominated by white verbal autistic adults.
Absolutely, yeah. So this was one of the things that we really wanted to approach with our network was really trying to move away from, like you said, sort of predominantly white participants. We have more diversity in it being a global sample, but we are still restricted, and if anyone has any ideas for how to kind of work on this further, we're still restricted really in the way we do sample towards majority white participants. And I do think, though, it's particularly important that we think about things like intersectionality. So not just, particularly in our autism acceptance study, it's not only important to think about how as an autistic person you might be part of a minority group in that sense, but also kind of ethnic minorities experience other additional sort of impacts and stress burden. So I actually really want to look at the role of intersectionality in the impact on mental health in autistic people, because I think it's never as simple as just simple autism acceptance or one identity predicting stress burden that an individual might experience. So yeah, at the moment that's one of our challenges, but we're trying to work on that going forwards to diversify more still, even within each of our countries.
Thank you. And then Julian Wignet, he's asking, sorry, you mentioned developing research opportunities for autistic people. What opportunities do you envisage?
Developing research opportunities, just trying to think of what I said. So I think, well, in general, having a sort of global network and being able to diversify a little bit our participatory network, but also our research network, hopefully allows for autistic people to be more involved in our research. So we ourselves at the University of Birmingham have a consultancy committee, which again is very sort of centric to Birmingham, but we're hoping to branch that out and have that as a sort of online participatory research group, whereby we actually get more diverse perspectives, and it allows people to contribute more when these sorts of participatory or consultancy groups are run via Zoom. Hopefully, I don't know if that does answer the question, but yeah, I mean, please feel free to email me if you're interested in hearing about other opportunities, whether that's as a perspective as a researcher or as someone who can, you know, advise us or yeah, give kind of consultancy in terms of the research we're doing.
Thank you. Then this question is from Ian Apperly. So Ian is asking, from an academic perspective, we would probably distinguish between different dimensions of neurodiversity, not limited to autism, but also including ADHD and dyslexia, for example. To what extent was this reflected in the concerns of autistic people in your study, either in terms of co-occurring challenges or in terms of common ground in establishing distinctive identities and rights?
Yeah, really nice question. Thank you, Ian. So I think some of our qualitative data spoke quite nicely to understanding not that it's not as simple as asking people about terminology and comparing, for example, neurodivergent to autistic. And a lot of perspectives said they wanted distinctions between those terms are not synonymous, so distinctions between those terms, so that they were able to represent their kind of autistic identity separate from perhaps other identities that they might manage. Just trying to think if I've answered that. To what extent is it reflecting the concerns? Yeah, so definitely we had concerns and things raised about their multiple different identities, and I think that's why also some of this research that we look at in autism acceptance and mental health, again, there are many other layers to consider there. It's I'm sure having multiple identities that one has to manage contributes to any sort of stress burden that might impact on mental health. Yeah, hope that's a useful enough answer, Ian.
And then this question is from Caroline Richards. So Caroline says, well, she's asking us, saying, thank you for a really great talk, Sophie. I wonder about intersectionality in your second data set. Do you think that the higher depression and anxiety scores in some countries could be driven by ethnicity? And she mentioned, was thinking particularly about being a minority in countries with history of racial discrimination.
Yeah, absolutely. I think, unfortunately, I don't know, again, if I can speak to that right now, because we have just looked at the kind of preliminary data, and we haven't broken it down yet by intersectionality, but the more I was sort of analysing the data and then putting together this talk, the more I think we need to do that. And we need to think about different, as you said, different things that are driven by ethnicity, because we know that minority ethnic groups also experience higher stress burdens that can contribute to mental health. So yeah, I really think that needs to be broken down, and this was a kind of superficial first look at the data, but yeah, watch this space hopefully for us to look more into those factors. Thanks, Caroline.
Then Christina Imagirs is asking, do you have contributors from Brazil?
So I have collaborators actually in Brazil, but not specifically in our autism research. So yeah, if you are a researcher from Brazil, or you know them, then please do reach out to me. I haven't managed to make connections with researchers in the autism field yet.
Thank you. And then as well, Christian Malone, so he was asking several questions, and then to answer one of the important one that he's mentioned here. So have you done a poll asking autistics what help or research do they want? Yeah, so I guess basically, this is some of the questions relate to that. So I guess he's asking how you are including, I guess, public and patient involvement in the development of your network. So how you are addressing this?
Yes, yeah. So so during our event, we ran some polls that asked the autism community. So that was both autistic people themselves, also friends and families, and other members of the public, what they see as the priorities for autism research. And so one of the polls I presented to you during the presentation. So a key feature seems to be mental health in autism, and therefore thinking about support and ways that we can adjust our health services and access to support so that it's as inclusive as possible for autistic people. And yeah, I think the main thing that came out of our event really was to think about reasonable adjustments for all individuals, but particularly for autistic people in environments that were not necessarily designed with autistic people in mind. I hope that's answered the question.
Thank you. And the last question, because yes, we are already running out of time, this is from Julian Binet. So were responses different between individuals in employment and those who were not?
Yeah, another interesting question. I guess maybe we were thinking about the second study. I haven't done those comparisons. We have got data to look at factors such as years of education, socioeconomic status, but actually looking at whether or not they are currently in and out of employment, I'm not sure we do have the data for. But that sounds like a very interesting question, because perhaps another factor that might contribute to difficulties with mental health.
Yeah, I guess now also with all the data that you have, I guess, is to get deeper into the understanding, I guess, of the different characteristics.
Yeah, absolutely.
So thank you very much, Sophie. Well, I guess that as well, because if there might be some other questions, so I guess that as well they can contact Sophie directly, or as well, like she presented the website, and as well where you can contact as well the network. So thank you very much, Sophie. Thank you very much, everyone who has attended today. So I think it's been very nice, and as you see, can be like so many questions, and people were really interested in this project. So congratulations and well done.
Thank you. Thanks very much for the invite, and thanks for the questions.
Thank you.
Okay.
Bye-bye.
Take care. Bye-bye.